I'd like to invite Natalie from Brisbane to be talking to us about C-spine injuries.
All right, so I'm first going to say I think these lights are the most sunshine I've seen in the UK since I've been here. So if I'm squinting, I apologise. I can't really see any of you at all. I'm going to be talking about what to do with pain in the neck, or as I alternatively sometimes think about it, is finding a needle in the haystack without raising the haystack to the ground, or getting a needle stick and missing an injury. This talk is largely in two parts. One is revisiting what we know about assessing cervical spine injuries or possible cervical spine injuries. And second part is a little bit of work we've done to start looking at what we're doing and what's happening in our centre. So it's at a much earlier stage of the research evolution process to what Ed's spoken about from a predict network point of view. I have a couple of disclosures, and well, I have no disclosures. I have a couple of disclaimers. Number one, if you came here for a metaphorical discussion on a pain in the neck, I can't give that to you unless it's over wine. Number two, nobody is an expert in this topic, really. I'm certainly not an expert in this topic, and I would be a fool to say that I was. There is still so much to know. And the third thing is I suspect this talk is going to give you more questions than it's going to give you answers. And that's where we all start. So I came into this topic. It sort of gravitationally shifted. I was involved in the head injury research and some of the work that we were doing about that. And I thought, okay, let's have a look at the neck. That's next, isn't it? So I came, I saw, and I was completely confused. There is What do we do? What should we be doing? What are the big questions in this area? Do we know what we're doing? Or is it just really, really easy? So really, for me, as a paediatric emergency physician, and I'm quite self-centered about that, the question is, what children do I need to be worried about? Who do I need to image? And who can I safely not? That's really my driving question when I'm assessing possible cervical spine injury. And do I need to image everybody? Do I need to set the bonfire to the haystack of all the children I see with trauma to try and find the one that has a cervical spine injury? Or how can I apply a slightly more refined tool and try and extricate it? But before we consider this, I guess we really need to consider, does it even matter? Like, why can't we just image everyone? Of course we can image everybody. We've got that test available to us, or certainly we do. Our radiologists might not like it so much if we did. But like all things, it's really a balance, isn't it? So it's, why do we want to identify all these injuries? We want to see if we can prevent unnecessary disability, possibly death, but a lot of the evidence suggests that that happens before they even get to us. I also want to prevent my own personal angst if I miss an injury, because that's a big thing for us, and I'll come back to that later. On the flip side, well, why don't we image everybody? There's the radiation that you all know about and that we're increasingly worried about, particularly pertinent to really little children. Some of the tests we do, the kids won't stay still. It's very unobliging of them, but we need to increase the risks of sedation, general anaesthetic, access to resources. It costs both for the test, but also for the amount of time in your already overcrowded centre or emergency department where these children are waiting for their tests. And if you've ever sat there with a child who's waiting for hour number 3 for a scanner to become available, the family starts getting a little bit twitchy and a little bit anxious, and the kid's trying to climb off the bed. So it is a balance. We really can't image everybody. So what tools do we have to help us guide this decision? You know, if we don't think we're absolutely brilliant and we automatically know, what tools do we have? What tools do you use in your centre? Don't know about you. Us, we use a mixture of the Nexus rule, the Canadian C-spine rule, sometimes pecan, which I'll come to in a little bit, and sometimes just what we think is best from a clinical gestalt point of view. If we look at that in a little bit more detail, let's have a look at Nexus. So Nexus included kids, had 3,000 and I think 65, but over 3,000 kids in the Nexus study. The median age of their paediatric population was 15, which is my upper limit of where I like to see, because I'm much more comfortable below the 16-year-old age group. Nexus had 30 paediatric cervical spine injuries in its entire cohort. 4 of them were under the age of 9. None of them were under the age of 2. They reported 100% sensitivity in picking up cervical spine injuries, but that's on 4 injuries under the age of 9. Their injuries were much more common with an adolescent population, or the type of injuries we see in that age group, rather than those younger kids. So to me, my questions are not quite answered from Nexus. Is that rule good enough for us, just looking at it on the spec of the paper? The other one is the Canadian C-spine. For those of you familiar, which I imagine quite a lot of the room is familiar with that rule, that rule, it's never been validated in children. We don't know whether it works. We use it, but we don't actually know, is it good enough for what we want to use? There are a couple of retrospective studies that were done that looked at their case series of cervical spine injuries and applied the rules to them. They found the rules missed a significant number, both of them, Canadian C-spine and Nexus, missed a significant number of injuries in the younger children, particularly those under 9, and a Cochrane review in about 2017 essentially said the same thing. There's really not enough evidence for use of either of those rules in the under 9 population or under 8, and it may miss things. Pecan came up with another study, because they tried to redress this, and they looked at 540-odd children who had cervical spine injuries, case-match controls, and came up with a list of 8 factors that they think are predictive with a 98% sensitivity. So it looks promising because it's about children. It's not yet been validated in a prospective fashion. So it's still go there with caution. The other question is not just who we image, but how should we image these children? I don't know how many guidelines, probably not as many as me, that you've compared on different ways to approach cervical spine imaging in children. But one of them says all kids should have plain films first. The other says, oh, maybe do a CT if they're high risk. Another one says, well, if you're going to do a CT brain, do a plain film of the lower spine and do a CT of the upper couple of vertebrae, because that's what we miss. Another one says, do a plain film, and if you're still worried, do an MRI scan. So there's a lot of debate as to which tests we should do, and obviously there's a lot of reasons for why we might do different tests. I'm not going to go through there, but the question doesn't stop at who we image. The rules offer us no guidance on which way we should image them either. So now I'm going to flick across to our study and what we did. Now, this is a little small single centre study we did over a year, just to try and get a bit of an understanding of, well, this is what the literature says about how we can assess cervical spine rules. Is it a problem at our centre? What are we doing? What are we seeing? So the study went for a year. It was prospective. It was observational. We looked at all children under the age of 16 who either came in with neck pain in the context of trauma, were immobilised because they had a possible cervical spine injury, so some of the whatever type of collar you use or don't use in your centre came in immobilised in that, or we otherwise considered they're at risk. For example, the kid that's fallen from the tree that's got a broken leg, but actually when you go through the story landed on the head, and so you're worried potentially they could have a neck injury. There are some exclusions. Penetrating trauma was one of them, consent, language issues. There is one population that gets missed in this, and that's we have a lot of kids that are under the Department of Child Safety, might be involved in high-risk MBAs. We can't get consent. They don't have modes of, abodes that they constantly live at. They're fairly itinerant and move around. So that may be a population of importance that we've excluded. What did we find? Well, we didn't find many cervical spine injuries, actually. Probably more than you would find giraffes living in the wild with their broken necks quite successfully. We had 65,000 presentations that year. We now have 72, so lucky me, going back to winter there in a week's time. 65,000 presentations. We saw 1,100 children who were eligible for the study. We enrolled just over 1,000. Of those 1,010 children, 37 had imaging before they got to us. We're a tertiary referral centre, so that's not surprising. And 973 had not. Of the 37 who'd had imaging, 9 of them had cervical spine injuries. of the 973 fresh children with no imaging, 5. 5 of them had cervical spine injuries. None of them needed an operation. 1 did die, and their cervical spine injury would or may have contributed to their death. They had a multi-trauma sort of setup of injuries. But that's 0.5% of children with cervical spine injuries in that population. I'll tell you a little bit more about our population, just so you get a feel for what we're seeing and if it compares to what you might be seeing. 2/3 of them are male, like a lot of trauma. Our median age was 10.9, so quite a bit lower than the Nexus median age. 16% of kids were under the age of 5, so it's about 1 in 6. 73% of our kids come in by the ambulance, so that's a nice healthcare resource we're using. 90% of our kids were triage category 3 or above in the Australian triage scale, so that's seen within 30 minutes or less. 60% of those, so 2/3 of those, were a category 1 or 2, so that's seen in under 10 minutes. So that's a lot of that's a large load on your emergency flow, processing, and how we look after these kids. Over half of them were due to a fall, just over half, and most of those were falls less than 3 metres. We did have some that were over the 3-metre mark. About 20% were due to motor vehicle accidents, and because it's an Australian study, I can't go anywhere without talking about sport. Over 20% of our population presented because of some football code. Now, I use that very widely. I use that from the perspective of league, union, soccer, and Aussie rules, but 20%, and that's across the whole year. So it just gives you an idea of the sort of mechanisms we're seeing from an injury point of view. 92% of our kids had a GCS of 15, so they were generally awake. About 45 or so had neck pain, slightly less had neck tenderness when they're in the ED. They might have had it beforehand, but that's in the ED, so it's just under half. Only 27% had midline neck tenderness. So that's a factor, if you're familiar with your Nexus rule, that's a really important factor in the Nexus rule. Only a quarter of our kids had that. About 3%, 4% had torticollis, about 6% had focal neurology. Now, before you go, oh, this is probably quite a, not very sick population, 26% had suspected significant serious other injury. And that definition, we used the PECAN definition out of their study, which is expecting hospitalisation, overnight, operative intervention, or need for an inpatient stay. And that didn't include short stay. About 16% had distracting injuries as per Nexus that might interfere with their neck injury assessment. So what do we do with these kids? What did we do? When we did a straw poll in the WISE Council, that is our consultant meeting before this study started, we thought we might image 1 in 4. Some people thought they were a bit better than that and image less. We imaged 2 in 5. So 2 out of every 5 children who came in, we sent through some form of imaging. What form of imaging do we send them through? Well, we X-rayed 32%, we CT'd about 13%, and we MR'd 3%. There are a lot of kids in that, as you can see from the diagram, that got both studies, or more than one study. A few lucky kids, I think about 7, got all 3. So there's room. Do we not know what we're doing? Are we not seeing what we need to be seeing on the X-ray? Should we have ordered a different test first? It's really hard to know. All right, when we look at first-line imaging, so what's the first test we pick? 3/4 of the time in our centre, we're picking a plain film. That's fairly consistent with a lot of the guidelines that tend to recommend plain films quite a lot. Very, very different to adult practice, where there's no real decision. If you're worried about a neck injury, just send them through the CT scanner. There's nothing to debate. Whereas in paediatrics, this is really still an area that we haven't sorted out yet. Of the CTs we did, about 2/3 of them were first-line investigations. So we picked, this kid I'm more worried about, I'm going to do a CT. We had a little bit of a look at, can we associate different factors with what made us image or what made us pick a CT over a plain film? Some were predictable, like your GCS was low. You had focal neurology, you had a higher risk mechanism. We were doing a CT brain as well, so we did a CT neck instead of a plain film. Some of them are not so predictable. When we looked at age, the rate of imaging we do with age goes up. That's almost essentially driven by the rate of plain films that we're doing. The CT rate, there is no statistical difference across the age groups, whichever way I broke that down, between our rate of CT use. That begs a few questions of its own. You know, are we just CTing the ones that we really need to CT in the young kids? Are there some adolescents that we don't think they have an injury, the pretest probability is low, we'll do an X-ray and if that's okay, it's happy? Are the teenagers able to complain more? Are there other factors at play that we haven't even thought about that may be influencing this pattern? So then we look at our tools. You know, we said we've got, I call them tools, I don't call them clinical decision rules because I much prefer the name when people call them tools, because if you say rules, we think we have to follow them all the time, and if you work in clinical practice, you know we don't follow them all the time. We adapt them to our own circumstances and what we think is best. So when we did this, all of the rules would have increased our imaging rates. So none of them would have helped us in decreasing our rates. Our rate was 40%. The way they would have increased our rates is between 44% if it was Nexus and 68% with the PERU rule. So that's a large increase in our imaging rates. What's more worrying is we've already said that we didn't have very many injuries. You know, we had a total of 14 in the whole cohort if I include those who'd had a bit of pre-selection and had some tests before they came to us. One of the rules, that was Nexus, would have missed 2 of those children and their injuries. So I'm not saying Nexus is bad, I'm just saying we need to think harder. So one question I have been asked more than once is, cervical spine injury is so uncommon, do we even need to worry about it? You know, we're unlikely to see it very much. Can we just pick it? Do all our patients come in like one of our cervical spine injury patients? He came in with the description, I feel like my head is slipping off. You know, is it that clinically apparent every time which kids actually have cervical spine injuries? The answer is we don't really know. There's some nice little lines written in paragraphs saying we may not pick them up, particularly in the younger non-complaining kids. Certainly we have anecdotal evidence of a young child who wasn't picked up for 4 days, who'd been involved in a multi-trauma accident. It was only when they came in with their ERTI and they weren't moving their neck that we worked out they actually had an injury. So, you know, we don't know. We don't know if we're very good at picking it up clinically or not. We only know the injuries that we find. So we need prospective studies to know, to even answer that question. More important than that, though, is we're worried about it. Like, we're clearly worried about it if we're imaging 40% of children. So that's 79 children in our centre get imaged for every 1 injury we detect. So it's clearly something we're worried about. So irrespective of whether we need to worry about it, we are. So we need to look at this further. Is there a better tool, or is there another way we can use these tools to work out who to image, how to image? Can we develop a better tool or rule to find this needle in the haystack without putting the torch to half of our population and subjecting them to radiation along the way? Maybe there's not, but I think we need to look. Do we need to consider that we use analgesia as an observation like we do in head injuries for a little while to better define that population of who we image and who we don't? There are some future efforts in this way. I know the US is looking at a big, large, multi-centre trial to assess both their PERU proposed rule and some other factors, and can we get a paediatric specific clinical decision rule for cervical spine injury? Certainly we are intending to look at it in Australia as part of PREDICT and the SONIC study, using the data that we have as a pilot. But I would put it to you, have a think about what you do in your centre. Is it something that you're worried about? What are your imaging rates? How important is it to you to have a better tool or a better way of assessing and framing this question? Thank you.
Thank you very much, Natalie. It's a really important question at the end. So for those of you who work directly in the emergency department, there are lots of stresses. So there's sepsis, there's bronchiolitis, there's major trauma. Sometimes it's not a little thing, but things like C-spine management can get missed, and there's always something at the top of the table. And I think Natalie's correctly pointing out is, have you reviewed your performance at all in the last couple of years? How many scans do you do, and what are their accuracy? Because I think that we may well be doing lots of unnecessary things. Katie, is there any specific questions?
There are, and I have Phil Nadeau, and I hope I'm getting your name right there. He asked, given the low sensitivity of plain films, what's the rationale for using it as a first line in the presence of ongoing midline tenderness?
Okay, I'm going to pull that apart in a couple of things. One is just on the issue of midline tenderness in the lower young paediatric population. There is some question whether that's actually an accurate discriminator, and PECAN just used neck pain rather than midline neck tenderness. So I'm just going to address that first, just as a side issue. I didn't touch on the sensitivity. I completely agree. Depending on which series you read, the sensitivity of plain films is anywhere between between 85 or 80 and 95%, so it can miss some significant injuries. I think the concern is there's obviously there's some risk stratifying to do in paediatrics. There are kids that probably, if we felt more confident, wouldn't need as much imaging, and I suspect that sometimes the plain films are used when you've got that low pretest probability to start with, and then they're just trying to make it lower. Never zero, but making it lower. Depending on which centre, some centres say there's not much difference between the x-rays by the time you've faffed around with your swimmer's view and your this view and your that view in plain films compared to a CT. Talk to our centre and the difference is huge. And we're a paediatric centre who does low-dose radiation. So I think there's still a few questions to be answered in the relative difference. And I think if we could decrease the number of children we're imaging and specifically better target, I think then we could go the TT is the much better test.
Brilliant. Thank you very much.
Thanks.
My personal view is I think the question that we had from Ed's about how we define respiratory distress is no different from what midline tenderness is. I think you take 100 people, they will all come up with very different conclusions. And you've got to be in absolute agony reproducibly and specifically for me to think you've got midline tenderness. If you're a young child, you're just going to say you're in pain, and that doesn't necessarily mean midline tenderness. Any other questions?
No, we don't.
Anything from the floor? Excellent. Now, we do have a microphone somewhere. So, there we go. Grace is sprinting down. Is it with me? Oh, here we go. No? Fantastic. Here we go.
Hi, I realise your numbers that actually had a confirmed injury were small, but did you look into those and see if they shared any common features?
So we have looked into them. They're in that in Australia, late primary school age, so they're sort of between about 6 and about 12, actually, so it's not even too many adolescents in the population. The mechanisms were quite varied. So we had trampoline, we had fell and slipped over, which is hardly reassuring for any of us. We had got rolled over and a tractor landed. So we had the full gambit. We had sporting injuries. You couldn't just pin down a specific mechanism to start with. As far as some kids came in at GCS 15, some clearly didn't and were tubed and were clearly in that very, very high risk group. So I would say the ones that came with pre-imaging, could there be a problem? Those kids often had less severe mechanism than the kids who we saw, and that may be a product that we're a primary retrieval centre. So if there's a major accident, the kids get choppered off the scene and sent straight to us. Whereas if you've gone through and managed to survive, 1 or 2 of the kids came from the private radiology. So, these things do exist. The other question people ask, well, if they didn't need operation, does it matter? And I guess I didn't touch on it on the talk, but the other thing I think about is it's a bit like concussion. So, no, it doesn't matter for the child at the moment, but if a child's got a ligamentous injury or some cord edema or something like that, is that a child that we should be sending out to play rugby in a couple of weeks' time. So would it affect our actions, and is there some other damage we're preventing down the track? So I'm not clear on that answer, and I said I was going to give you more questions, and I gave you answers, but I think it's something that we need to think about.
That's a really good challenge. Has anyone been involved in a case where they sent a child home who hasn't had a bony or spinal injury, but weeks down the line there's been a complaint or something because a ligament injury has got worse? Has anyone had that experience? Interesting.
Yeah, no, agree.
Oh, thank you. Any other questions? No. Oh, was there one? Sorry.
She was just saying hello to someone.
That's the best question I've had.
Fantastic. Thank you very much, Natalie.